This is the sixth presentation in GIT 6 trauma. Here in this slide we can see the value of the 3D reconstruction with the multiple fracture ribs and a line of fracture scapula here. In this one you can see the value of reconstruction in showing the instability. There is fracture of this vertebra, and here we get a piece of bone inside the spinal canal, so this is encroachment which should be studied. Here we get the fracture line, and here another fracture line. There is some sclerotic deformity and compression, which is called lateral compression of the vertebra. This area is diminished in height than this area. And here we get the compression of the spine of the vertebral body with anterior bulge, which could be a hematoma again. This can increase the size of the prevertebral soft tissue if there is a hematoma. And here there is bulge, light bulge of the vertebral body into the spinal canal, interrupting the middle column. The middle column is containing the cerebrospinal fluid and the cord. If there is bulge, that means there is compression. A bulge is called lumbar instability. We should be aware of soft tissue injuries associated, and thus we resort to MRI to see if there is prevertebral hematoma or spinal encroachment by hematoma, or cord laceration, means cord blood here. So trauma can deduce that these changes in the vertebrae, these changes, if not encroaching on the spinal canal, will be dealt with conservatively. If encroaching the spinal canal, that means that lumbar instability, which should be searched for. And remember the concept of the three columns: anterior column, middle column, posterior column. The third thing is that to study well the soft tissue inside and soft tissue around here and there, we should resort to MRI for blood or hematoma inside the canal, or hematoma around, or hematoma within the cord, which is called cord laceration. So the word cord laceration means blood within the cord. Or you can get cord edema, and later on cord malacia. This is something else. Here we get this sternoclavicular dislocation. So in trauma, check the bony outline of the part examined as this chest. There is a sternoclavicular dislocation. Here there is fracture sternum. There is fracture of the sternum and some hematoma behind, collection of blood. And here we have the soft tissue opacity around a rib with lung contusion and pleural minimal collection, and there is increased density within that soft tissue, denoting the blood collection of the hematoma. So there is hematoma around the rib associated with lung contusion and pleural minimal collection. Trauma could be iatrogenic, resulting in such an appearance, rupture of the esophagogastric junction. This is the tube, and here is the contrast seeping around. There is leakage of contrast, and there is leakage of contrast around the fundus. Leakage of contrast around the fundus. And this is the air in the fundus, and this is the contrast within the lumen, and this is the contrast outside the lumen. So we have contrast in air, contrast out tube, and contrast leaking from the distal esophagus. Rupture of the esophagogastric junction occur in severe vomiting and occur in iatrogenic or post-operative changes. This one have some clips here, so this is post-operative. Now this one, normally there is difference between the ascending and descending aortic diameter. The ascending should be more than the descending. The difference is between 5 to 4 or 3.5 to 5 to 3.5. So it is either 20% reduction of the caliber here or more, but not less than that. Now here in this case we have similar caliber. Similar caliber means that there is something dilatation, and dilatation means aneurysm. So there is a start of aneurysm of the descending aortic arch, and the relation of trauma will be seen here. Now this part is called a hidden area because it is covered by this. I mean, it is anterior. Nobody will notice that there is some small bulge there, except if you put in mind that in trauma the sternum is compressing, and compression will cause subintimal and intimal tear, which result in such an appearance. This is pseudoaneurysm of trauma, post-traumatic pseudoaneurysm. If extending, it will result in such appearance if extending posterior. Now this one show the fundal bulge above the diaphragm, and this constriction is called the gastric collar. That means the diaphragm is interrupted in some part here, and this one, the spleen is partly outside and partly inside the abdomen, bulging above the diaphragm. This is the diaphragm, and the constriction here is called the splenic collar. So the structure, the constriction made by the diaphragmatic rupture will compress the visceral structure, as in here or there. If stomach, it is called gastric collar. If spleen, it's called splenic collar. Sometimes there is also hepatic collar. This is a hepatic collar sign. The part of the liver is above the diaphragm, bulging into the chest due to rupture of the diaphragm. So ruptured diaphragm can cause gastric bulge, splenic bulge above the diaphragm, or hepatic bulge above the diaphragm, and the constriction area is called the collar, gastric collar sign, splenic collar sign, or hepatic collar sign. Now this one is what we call the sentinel clot. Sentinel clot is the main blood source of the hematoma. Here we have irregularity of the spleen and low density areas inside, and in discontinuous outline. That means that there is tear of the spleen. The measurements of this collection is higher than the measure of this collection, so that our direction should be to this side. That means that there is an ooze here, there's something oozing and not there, and what is collecting here is the serum, supernatant fluid. The collection here is the uh, 60, while here is 23. 61 in this area and the 23 in this area. That means blood is collecting in this side. This is what we call sentinel clot. It is the blood clot adjacent to the bleeding site. So the blood clot adjacent to the bleeding site is called sentinel clot. If you find the density is higher on one side, that means bleeding is coming from this area. If the reverse, it is from this area. So sentinel clot means blood clot near to the bleeding site. You will be able, if you do dynamic study arterial phase, to see the intrasplenic or intravascular bleeding, and in this case the spleen is torn off and there is some bleeding inside. Here there is bleeding intraperitoneal. There is something bleeding intraperitoneal with the shattered spleen and bleeding intraperitoneal. Here is an pseudo aortic aneurysm with resultant splenic infarcts. And here we got large subcapsular hematoma. The liver is compressed here and there is a collection in this area and not free. It's not free in the abdomen, it is localized in this. So it is a subcapsular hematoma with active bleeding inside. Here we get the liver laceration. There is interruption of the parenchyma of the liver, post-traumatic. This is called liver laceration. Another liver laceration involving most of the liver, and take care of three items. First, that the IVC is seen slit-like, and this means hypotension. And the second is that once you find this laceration reaching medially, take care about the hepatic veins, mainly the right hepatic vein, because once the surgeon go into the theater and start to manipulate, this hepatic vein will gush blood in this area. So this split IVC indicates shock, and this laceration is reaching to the medial aspect, so we should be aware about the hepatic veins here. And thirdly is that the collection or the blood is mainly on the side and not on that side. The density here is higher than this, so it is the oozing area. This is the oozing area. Liver laceration. The liver could be lacerated and the gallbladder could be lacerated also. This is an extreme post-trauma advanced condition. And the pancreas could be lacerated also, or completely shattered, or shearing injury due to shearing against the vertebra. This is again post-traumatic. Of course, trauma of the pancreas involving the pancreatic duct should be repaired, but trauma of the pancreas without involving the pancreatic duct is usually treated conservatively. Now here we have the slit, again the slit IVC indicating hypotension, and you get large hepatic renal hematoma with multiple lines of disruption. That means that it is a severe hepatic and renal injury with slit IVC due to hypotension. Any triangular shaped collection is an intraperitoneal fluid. Any triangular shaped collection like that is intraperitoneal collection. If it is dense, it will be free intraperitoneal blood. So take it in consideration that if you find any triangular collection, it is fluid intraperitoneal, and if it is dense, it is blood. Here, what makes these loops are not seen? Because there is very luminal blood. They are called matted together loops. Matted together means they are aggregated together, but this denotes small intestinal injury with blood around the loops. So the presence of blood around loops should raise the possibility of small intestinal or loop injury. Here we get small collection, triangular again, near to the duodenum or duodenum, last part of duodenum, and this is a hematoma. Renal contusions, of course, any abdominal trauma could be associated with renal involvement, and here we get some part of the parenchyma well perfused and some part is not. Areas of decreased enhancement or focal underperfusion is due to renal contusions. We can get the famous subcapsular hematoma, and here it is subcapsular because it is limited to the confinement of the kidney and not outside the kidney. If outside the kidney and enclosed in a line here, not going into the peritoneum, this is called Gerota fascia, and if it is not confined to that line and it is just anterior and posterior, it is retroperitoneal pararenal collection. So we have three types of collections. This collection, which is a subcapsular, limited to the confinement of the kidney. You can draw the kidney, still the kidney is there, and this one we have the kidney shattered or disrupted, and then we have hematoma limited to this area, so it is around the kidney, so it is perirenal, and going anterior it is pararenal, it is bulging anteriorly. So this is called renal fracture because the line of disruption or the laceration connect two sides. It's called renal fracture. The trauma of the kidney could be, as we said, contusion, could be subcapsular hematoma, could be perirenal collection, and we should differentiate between two collections: Gerota fascia, within the Gerota fascia, or outside the Gerota fascia, or within the peritoneum. So we have three collections around the kidney. One, the kidney being retroperitoneal. If there is collection limited to the retroperitoneal, it could be within the Gerota fascia, and in this case it will seeps down to form the urinoma, the famous urinoma, because Gerota fascia is free down but closed laterally and superiorly. And if in the pararenal fat outside the Gerota fascia, it will bulge into the peritoneum like that, but it will not soil the peritoneum. If soiling the peritoneum, that means that there is a communication between the kidney retroperitoneal space and the peritoneum, which is rare. Here in this case, we have both intraperitoneal and extraperitoneal perirenal collection, but the kidney itself is not perfused and it is something swollen. So swollen non-perfused kidney is denoting renal vein and renal artery tear. Here we have the devascularized kidney surrounded with hematoma, which is different from that hematoma. The hematoma here is intraperitoneal. The hematoma here is outside the peritoneum, is retroperitoneal, and if limited to the around the kidney, it is called hematoma within Gerota fascia. If seeping around like that and starts to reach other parts in the retroperitoneum, it is pararenal hematoma. Large non-perfused kidney is due to renal vein tear or thrombosis or occlusion. The difference between retroperitoneal and peritoneal, of course, this is peritoneal, and here it is around the kidney. It is retroperitoneal, limited by the line. So long it is limited by the line, so it will be contained within Gerota fascia. If these areas are soiled, it is pararenal hematoma. Pararenal hematoma is within the fat around the kidney, while hematoma within Gerota fascia is enclosed with a capsule which is tight laterally, posteriorly, and medially due to fibrosis, and upward it is closed, but downward it can go down to reach the iliopsoas region. Here we have injury with perinephric hematoma and air. That means that there is communication around. Now we can see classically that there is a line here and there is some collection around. The collection around is in the pararenal. The collection here is in the Gerota fascia, and of course we have checked the subcapsular hematoma before. So we have three spaces around the kidney: capsule, Gerota fascia, and pararenal, posterior pararenal space, and the anterior pararenal space. Here there is air denoting communication with the outside, and here there is peritoneal blood. That means associated intestinal injury. Injury can involve the pelvic cell system, and here once you do IVU, you will find contrast leaking from the kidney, which collect again in Gerota fascia and starts to form urinoma. So this is a urinoma enclosed by Gerota fascia. The one here is the urinoma enclosed by the Gerota fascia. And this is the sequence after a while, 1 or 2 months. A large collection of urine is seen. This collection is starting here. This is the kidney, this is the urine within the Gerota fascia, and then downward it will show such an appearance till it reaches down to the iliopsoas region. From this we can get the anatomy of the Gerota fascia clearly, that it is closed on that side, closed posterior, closed anterior, closed medially by the fibrous tissue around the aorta and the IVC. But in infancy this area is loose, so the kidney can cross to the other side, but in the old age the kidney cannot cross to the other side because of the fibrous tissue around the aorta and the IVC in this region. So we have Gerota fascia closed anterior, closed lateral, closed posterior, closed medial, closed upward, but not closed downward. It reaches down to the iliopsoas fascia. What's the difference between contrast outside and the peritoneum and contrast inside the peritoneum? If outside the peritoneum, it causes the flame appearance as if something irregular, because it goes in the interstices around in the fatty tissue around the urinary bladder, or it can collect in this way. If large, it will give the molar tooth appearance, and the bladder should be in between here, compressed. And such an appearance could be differentiated here. Here is the bladder. Here are some flames. Here are the flame. This is extraperitoneal. Here is the flame extraperitoneal, and there is some inside this intraperitoneal, and here is definitely intraperitoneal. Triangular shaped collections are usually intraperitoneal, while flame shaped or molar tooth appearance are extraperitoneal. Molar tooth appearance can be also seen in such cases if there is fat. This is lipomatosis compressing the bladder. If there is hematoma, as in here, extraperitoneal hematoma will compress the bladder, and if there are masses like lymph nodes, it will compress the bladder. So masses, hematoma, extraperitoneal hematoma, and fat can produce the same appearances in a bladder, will be appearing as compressed from side to side. Now this is the last. Here we have the deep vein thrombosis, sometimes occurring in people post-traumatic or post-operative period, will show this deep vein thrombosis. And thank you.